Okay, thank you. So I'm going to continue the series of talks, and this one will be a very similar talk, and this one will be on the apical or the middle compartment and the posterior compartment. So again, I have no pertinent disclosures, and the objectives are very similar in this particular case to talk about the apical and posterior compartment. And as we talked about already, pelvic floor dysfunction is very common, and what we're doing here is we're trying to image patients that present with dysfunction of the repair procedure. So again, going back to our chart for the different pelvic floor surgery, we talked about the anterior compartment. Now we're going to focus on the apical and posterior compartment. And in the apical and posterior compartment, the big condition you're looking at is pelvic organ prolapse, as well as defecatory dysfunction. And so we will focus on repairs of pelvic organ prolapse, which include native tissue repair, biologic or absorbable grafts, synthetic transvaginal mesh, and transabdominal sacrocopopexy mesh, as well as rectopexy. So we'll focus most of our time on the synthetic transvaginal mesh and the mesh sacrocopopexy, and I'll show you an example of a rectopexy as well. So again, the goal here is to image patients to identify what surgical material has been placed, because oftentimes they've had so much surgery, they don't remember which surgery they've had. They come to a different doctor, and the different doctor does not have the history, the proper history, and so our job is to identify what surgical material is present, and then detect complications as well and provide a surgical roadmap. Now for the apical and posterior compartment, MRI is more useful than ultrasound, and I'll show you examples. So again, just briefly, in case you missed it in the first lecture, our MRI pelvic mesh protocol consists of 2D T2-weighted axial, coronal, and sagittal images, as well as a sagittal 2D T2 fat suppressed image. This can be performed in any plane. We do a sagittal because it's a faster acquisition than the axial. And then we also perform, this is optional, but if you can, it's good, an axial 3D T2-weighted image. Again, a very thin section, an isometric acquisition, so you can reconstruct this in any plane. Axial T1 gradient in and out of phase images, as well as pre and post contrast T1 weighted fat suppressed images. So again, going back to normal pelvic floor anatomy, I'll talk about the anatomic structures that are pertinent to the apical and posterior compartment. So this is the H or butterfly-shaped vagina on the axial image, on the sagittal image, on the coronal image. This is the levator muscle, or the puborectalis more specifically. And in this talk, we're going to be talking about mesh that's placed anterior to the vagina, posterior to the vagina, and sometimes it's going through the puborectalis muscle into this space, which is the ischiorectal fossa. This is an important space to also evaluate. So again, very important to know the anatomy and where to look for these surgical materials. Okay, so the first thing we'll talk about is the transvaginal mesh. So transvaginal mesh is similar to the urethral sling, except the urethral sling is like a ribbon. This is more of a sheet of mesh that is placed. It can be placed along the anterior vaginal wall, the posterior vaginal wall, or like in this example, in both. There's different products that were made, and some were made only to place along the anterior wall, some were made to place along the posterior wall, and some, like this one, were made to be placed anterior and posterior. And then the way these are fixated is they have these arms that are extend in various locations. So in this particular case, you can see this arm of the posterior mesh is going through the sacrospinous ligament, but the arms of the anterior mesh are going through the obturator foramen. So there's lots of different variations of where these arms can go. So it's important to look in all of these locations. And here's a video, again, showing this is the anterior mesh. This is the posterior mesh. You can see the arms going posteriorly and anteriorly, and I'll show this video so you can see how complicated this can be and how the mesh arms can go in various different locations. And as our job as radiologists, it's important to look in all the different places for these mesh segments. So how does it look on MRI? So let's start with the normal appearance of the vagina on MRI. This is a patient that does not have any anterior or posterior vaginal mesh. Okay, this is normal fat space between the anterior vaginal wall and the bladder without any mesh, and normal fat space between the posterior vaginal wall and rectum, again, without any mesh. This is the sagittal image, and this is the axial image. For comparison, here's a patient that has mesh. So again, this is centrally is the vagina, and the yellow arrow here are pointing to the anterior vaginal mesh. You can see this dark structure that is kind of along that anterior wall, again, along the anterior wall of the vagina, and this is a dark structure similarly along the posterior wall of the vagina. And you can see this both on the sagittal and axial image. You can see this arms here. This is the body of the mesh anteriorly and the body of the mesh posteriorly along the vaginal walls. Important distinction here is this: the way this is placed, it's placed transvaginally. So the surgeon will make an opening in the anterior and posterior vaginal wall and then place a sling through the vaginal wall. And that's why this mesh is actually more susceptible to eroding back through the vaginal wall, because it's placed transvaginally. And then when you keep looking at this, you can see how, as I mentioned before, this is the puborectalis muscle, and you can see the mesh, the arms are going through the puborectalis muscle into that ischiorrectal fat. So very important to look for the mesh to be going through the puborectalis into the ischiorrectal fat. That's how you know this is mesh, okay? If you also look posteriorly, you can see this arm is going through the sacrospinous ligament, which is this structure, and it's going back into the ischiorrectal fossa. So it's very important to always check the anterior vaginal wall, the posterior vaginal wall, the puborectalis, the ischiorrectal fossa on either side, and well as the sacrospinous ligament, to make sure that none of the mesh arms are going laterally there. Now this is a different patient, and at first glance this looks like there was mesh here, but you see there's nothing going into the ischiorrectal fat. Okay, so this actually is not mesh, this is scar tissue. And this is a pitfall. It's very difficult for us to differentiate scarring from mesh. So when I see this, what I say is I see a band of dark tissue between the posterior vaginal wall and the anterior rectum. This could be from primary repair. It could be scarring from primary repair of the fascia, or it could be mesh. Okay, if I see the arms going laterally, I'm more sure this is mesh. But if I don't see the arms going into the fat, then I cannot be sure this is mesh or scarring. Here's a different patient. This one has a posterior mesh. So you can see this is the rectum and this is the vagina. So this dark band that's placed between the rectum and the vagina is the posterior mesh. You can see it's along the anterior rectal wall. And again, this is the puborectalis muscle. The arm is crossing through the puborectalis muscle into the ischiorrectal fat. And if you keep scrolling down, you can actually follow these arms nicely in the ischiorrectal fat. Again, for comparison, this is a patient that does not have any mesh. You don't see anything between the posterior vaginal wall and the rectum, and nothing is going through the puborectalis muscle, and there's nothing in the ischiorrectal fossa, just for comparison. So what are some of the complications? So as I mentioned, these patients often present with complications: infection, fistula formation, collection, abscesses. Patients can present with dyspareunia, groin pain, and then the most feared and most common unfortunate complication is vaginal extrusion. And this has been reported in up to 18% of cases. And this is a complication that is this high specifically in transvaginal mesh because these are placed transvaginally, as I mentioned. And so because of that, the FDA in the United States has banned all posterior mesh in July 2018, and in April 2019 they banned all the anterior mesh. So as far as it goes in the United States, the anterior and posterior vaginal mesh are no longer being sold on the market. However, these patients may still be around because they have had these procedures done way before 2019 and 2018. So it's important for us to be able to know what they look like and recognize the complications. All right, so these are two videos from the same patient. Patient has a history of posterior vaginal mesh and presented with dyspareunia and vaginal bleeding. This is a 2D image and this is a 3D image. I just want to show you what the difference is between the 2D and the 3D. So if you follow the video on the 2D image, you can see the mesh coming on the right side, and it's really hard to see because it's a thicker slice. So here's the mesh coming on the left side, and there's some thickening there. And let me pause it there. So this is the arm of the mesh, but it's very hard to see on the 2D image. This is the left arm of the mesh. You can, again, you can see how it's difficult to see. It's coming here, and then it comes behind the vagina there. Now pay attention on the 3D. It's actually much easier to see. You can see this is the arm of the mesh. You can see it much better between the rectum. This is the left arm of the mesh. You can see it much better between the rectum and the vagina, and you can see this abnormal thickening here on the left side. So the 3D images, although they are more prone to artifact, when they come out properly, you can see the mesh a lot better on the 3D image than the 2D image. If you go back, you can notice it there, but it's easier to see on the 3D image. So this is the same patient, just some static images. You can see this is the normal right arm of the mesh, The left arm is very, very thick. The left side of the mesh is very thick. And you can see right behind the vagina here, it's very, very thick and abnormal. And then this patient on vaginoscopy actually had the mesh coming through the vaginal wall into the vaginal canal. So this was extrusion of the vaginal mesh into the vagina. And this is what we predicted based on the MRI because this is so abnormal on the left side. How about what does it look like when there's fistula or infection? So this is anterior vaginal mesh. You can see this dark structure here, but you can see there's some high signal intensity here on the T2, and you can see this is it along the anterior vaginal wall on T2. There is some kind of a tract going to the right side. When we look on the post-contrast images, you can see this tract goes into the right ischiorectal fossa and forms a collection, and you can see how it's actually forming this large collection on the sagittal T2 fat-suppressed image, and this was fistulizing to the skin surface. So this anterior vaginal mesh caused a tract to form along the arm that was going into the right ischiorectal fossa. There was a collection, and then it fistulized to the skin surface. So this is, again, one of the unfortunately common complications of these materials. This is a different patient, and you can see that the posterior bladder wall is very, very thick. You can see this patient actually had both a sling as well as a vaginal mesh. This is the vaginal mesh arms in the ischiorectal fossa. These are the sling arms. So you can see how thick this bladder wall was posteriorly, so we suggested that this may be some erosion, and here is the cystoscopy image showing the mesh in the bladder. Okay, so whenever you see abnormal thickening and enhancement of the mesh or the sling, you have to suspect that there may be some erosion. So to summarize, this is transvaginal mesh. You're looking for low signal intensity on T2 along the anterior or posterior vaginal wall. Some of the complications include infection, fistula, exposure or extrusion. And then MRI is used more commonly than ultrasound. And that's mostly because you're looking for complications along more distant arms of the mesh than close in the perineum. So the MRI is more useful in this setting. Okay. Moving on to mesh sacrocolpopexy. This is also similar polypropylene mesh. The difference is this is placed transabdominally. So the rate of complications is lower. The way this is placed, it's placed from the sacral promontory to the vaginal apex. You can see it's going from the promontory to the vaginal apex. It typically has this extension along the anterior vaginal wall and posterior vaginal wall, and it goes to the sacral promontory. So because of this, it's able to hold up the apex of the vagina as a repair for apical prolapse. Here's what it looks like on MRI. On the sagittal image, you can see this dark T2 band going from the sacral promontory to the vaginal apex, and this is what normal sacrocolpopexy mesh will look like. On the coronal image, you can see it typically has this curve towards the right side of the patient, and that's because this is placed extraperitoneal, and the sigmoid colon takes up typically the left side of the pelvis. So this is placed usually on the right side, and the peritoneum is closed over it, and the reason for that is to prevent any kind of complications with the bowel and the pelvis. So the complications include, again, extrusion. However, the rate is 3 to 5% compared to the transvaginal mesh I showed you, up to 18%. And that's because this is placed transabdominally, not transvaginally. But you can also have infection, osteomyelitis. And osteomyelitis is a unique complication because this attaches onto the bone and certainly can cause bleeding as well. So here's a patient with a very abnormal mesh. This is, compared to the last one I showed you, this is very thick and has high signal intensity on T2. You can see how thick it is, and this high signal intensity on T2, this is because of infection. Okay, and on the axial image, if you're just looking at one axial image, this can almost look like a bowel loop, but it's important to follow this up and down and look on the sagittal and coronal images to make sure you realize this is going from the promontory to the vaginal apex. This is infected sacrocolpopexy mesh. Here's a different case. Again, very thick mesh going from superior, from the promontory to inferior at the vaginal apex. This patient actually has a cervix. So this is a supracervical hysterectomy. So it's going from the sacral promontory to the cervix. In this case, it's thickened and high signal intensity on T2. It's infected, and you can actually see some enhancement at the bone. So this patient actually had osteomyelitis associated with this infected sacrocolpopexy mesh. How about this one? This is another patient that came in with vaginal irritation after sacrocolpopexy, and you can see this mesh is very tight. You can see typically has a right side curve. This is one single straight line from the promontory to the apex. So this is a very tight sacrocolpopexy mesh, and there's something going on here at the vaginal apex. We cannot tell what's going on. When we place the vaginal gel, you can actually now see that the mesh is inside the vaginal lumen. This is abnormal. This case is published in this paper with some of our colleagues, and this was done from their institution. So it's a very nice case showing the utility of using vaginal gel when you're suspecting erosion or extrusion of mesh into the vagina. To summarize the sacrocolpopexy mesh, this is a normal patient that does not have any sacrocolpopexy mesh. You see there's nothing between the sacral promontory and the vaginal apex. This is a normal mesh going from the sacral promontory to the vaginal apex, has the normal right-sided appearance, and this is an example of one with infection. You can see how much thicker it is, and it's got some high signal intensity on T2 because of the infection. And again, MRI is typically preferred in this setting. The last thing I'll show you is a rectopexy. This illustration I borrowed from a publication that we have coming out later on this year in radiographics. I have worked with some great colleagues from France, and this should be in radiographics either the end of this year or beginning of next year. But rectopexy is a procedure that's used for rectal prolapse. It may be performed by itself, or it can be performed with the sacrocolpopexy. What we do is we actually attach the anterior rectal wall to the sacrum because that's what is prolapsing in this case. So that's what rectopexy would look like, would be attachment from the promontory to the anterior rectal wall. So here's a patient. I'm going to take you through a few images. This is a patient that had a history of prior sacrocolpopexy. So this patient has this mesh going from the promontory to the vaginal apex, and then this is it on the sagittal image. I'll have you follow this from here, 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 and you can see this is what the sacrocolpopexy mesh looks like. On the axial image, here it is, here it is. It's coming down from the promontory here and attaching to the vagina. That's the mesh sacrocolpopexy, okay? But then the patient came back and had rectal prolapse. So the sacrocolpopexy was performed for apical prolapse, but now the patient, you can see on this MR defecography images, this is the rest, this is the defecation. You can see how much the rectum and the anorectal junction is descending compared to the baseline, okay? So then they said, well, now we need to do a rectopexy, and they did a rectopexy, and this is the same patient. This is the sacrocolpopexy mesh, but you notice this additional mesh that was not there before, the white arrow is showing you, is going from the rectopexy mesh, and as it travels, it goes, here it is here, going towards the rectum, and this is what the rectopexy will look like, attaching to the anterior rectal wall. And here it is here, going from the sacrocolpopexy mesh. This dark line here is newly placed rectopexy mesh to the anterior rectal wall. So this is very subtle, but this is what we're looking for. And then you can see after the rectopexy that the rectal descent is much improved compared to the pre-rectopexy image. Okay, so to summarize this lecture, we talked about transvaginal mesh, mesh sacrocolpopexy, and rectopexy, and this is some examples of what they look like. These patients often present with multiple prior surgeries and with various different complications, and our job is to help identify what surgery was done, identify the complications, and help with surgical planning. And ultrasound and MRI is used for this. For the apical and posterior compartment, MRI is more useful. And again, very important to know where to look. You want to look along the anterior and posterior vaginal walls, the ischiorectal fossa, the sacral promontory, as well as the anterior rectal wall. Thank you very much for your attention.
Okay, thank you very much, Gaurav. This is a very difficult topic. Maybe next year